Endoscopic ultrasound-guided transmural approach versus ERCP-guided transpapillary approach for primary decompression of malignant biliary obstruction, a meta-analysis. Introduction. Endoscopic retrograde cholangiopancreatography, ERCP, is the established method for biliary access for both diagnostic and therapeutic purposes. Biliary cannulation rates associated with ERCP are generally high, at greater than 90%. However, when faced with malignant biliary obstruction, which can often involve the ampulla, ERCP success rates drop significantly, especially at low-volume centers. Historically, when ERCP fails to achieve drainage in cases of malignant biliary obstruction, percutaneous drainage or surgical bypass have been used as secondary rescue therapies. However, these procedures are associated with considerable morbidity and mortality. Endoscopic ultrasound, EUS, has become increasingly available as a resource in recent years, with several indications for which EUS is now recommended as a first-line diagnostic or therapeutic modality. EUS can be used to facilitate biliary access through the rendezvous technique, where a guide wire is passed into the bile duct and through the papilla under endosonographic guidance. Alternatively, direct transmural EUS-guided biliary drainage, EUSBD, is also a well-described technique for biliary drainage in cases where transpapillary access via ERCP is unsuccessful. Multiple approaches to EUSBD exist, including choliticoduodenostomy, CDS, and hepatogastrostomy, HGS. The optimal approach is decided based on the site of obstruction and the degree of ductal dilation. A recent meta-analysis reported a functional success rate of 92% with EUSBD, with higher success rates for malignant obstructions compared with benign obstructions. A more recent retrospective series of over 40 patients demonstrated a clinical success rate of 98% for EUSBD in the secondary decompression of malignant biliary obstruction. Given the mounting evidence for this approach, there is a rapidly growing interest in using EUSBD as a modality for primary decompression in patients with malignant biliary obstruction, rather than restricting its use to cases where ERCP fails. It is plausible that EUSBD may be more favorable than ERCP in certain instances, as it has the ability to provide direct biliary drainage, even in cases of difficult ampullary access or complete distal obstruction. In so doing, one can avoid multiple ampullary cannulation attempts in these patients with challenging anatomy, thus decreasing the rates of post-ERCP pancreatitis, which has been confirmed to occur even with guide wire cannulation alone, at rates of greater than 10% when lengthy or multiple cannulations are attempted. Few studies have assessed the clinical performance characteristics of EUSBD compared directly with ERCP in the primary decompression of malignant biliary obstruction. Generally, sample sizes in these studies have been relatively small. Given this potential role for EUSBD, the authors conducted a systematic review and meta-analysis to compare relevant outcomes between EUSBD and ERCP as first-line therapies for decompression of malignant biliary obstruction. Background: primary decompression in patients with malignant biliary obstruction can be achieved via endoscopic retrograde cholangiopancreatography, ERCP, with transpapillary stenting, or, more recently, via transmural endoscopic ultrasound-guided biliary drainage, EUSBD. It is unclear whether either approach is superior in terms of clinical success or adverse events in the primary setting. Methods: a comprehensive systematic electronic search was performed for studies comparing EUSBD and ERCP as the primary approach with respect to clinical success and any other outcomes. Pooled relative risks, RRs, and weighted mean differences were obtained as appropriate using Der-Simonian and Laird random effects models. Sensitivity analyses were also performed. Results: 5 out of 775 studies with a total of 396 patients were included. Overall clinical success was not significantly different between EUSBD and ERCP. RR 0.98, 95% confidence interval, CI 0.93 to 1.03. There was no significant difference in overall adverse events, RR 0.84, 95% CI 0.35 to 2.01, though results suggested that EUSBD may be associated with a reduced risk of pancreatitis. RR 0.22, 95% CI 0.05 to 1.02. There were no significant differences between EUSBD and ERCP in terms of procedure time or the risk of stent occlusion. Conclusions. EUSBD had similar clinical success rates and occlusion rates to ERCP in the primary decompression of malignant biliary obstruction from meta-analysis including a modest number of patients. EUSBD may be a practical alternative to the ERCP-guided approach in such patients, but further well-designed prospective studies with larger numbers of patients are required to more clearly delineate potential differences in adverse events and cost.